this theory believes that prostaglandin is released as a result of the adrenal, uterus, and the fetus interacting with one another. Prostaglandin causes labor to start. Still another theory is the aging placenta theory, which states that as a pregnancy progresses, the placenta begins to age, and this results in insufficient nutrients reaching the fetus, leading to labor. And then another theory is the progesterone deprivation theory, which posits that labor begins when progesterone levels in the body decrease, which causes changes in the uterus, leading to labor and subsequent delivery. So, with all these theories combined together, that is probably the reason, or scientists probably believes that these are the reasons why labor onsets, why labor and delivery starts. Okay, so what are the factors affecting labor and delivery? We have what we call as the four P's of labor. The four P's of labor are the affecting factors of labor and delivery. So first P is the passageway, which refers to the vagina and the pelvis. Alright, there are basically four main pelvic types: the gynecoid pelvis, android pelvis, and anthropoid pelvis. So the opening of the four types of pelvises are illustrated in these drawings, no? So the first, the spherical, is the gynecoid pelvis rather. The gynecoid pelvis is round, it's wide, it's deeper, and it is the most suitable pelvis for pregnancy. This second drawing is an illustration of an android pelvis. The android pelvis is heart-shaped, and it is called as the main pelvis. As you can see in the drawing, the anterior part is pointed, and it is shallow. This type of pelvis makes vaginal delivery difficult. So most likely, if a patient has this kind of pelvis, then the delivery best suited for this is a cesarean section. Now, this third illustration suggests of the shape of an anthropoid pelvis. I mean the shape of the opening of the anthropoid pelvis. The anthropoid pelvis is an oval or ape-like pelvis. The anterior-posterior diameter is wider. Okay? Then, while the transverse diameter is more narrow. So if the mother has this kind of pelvis, most likely a delivery mode is assisted vaginal birth, usually with forceps. So later on, you will know what are the different types of delivery. And then this fourth drawing or this fourth illustration is suggestive of the opening of a platypeloid pelvis. So the platypeloid pelvis is a flattened pelvis. And this type of pelvis makes vaginal delivery difficult as well. So most likely if a mother has this kind of pelvis, cesarean section delivery is also prescribed for her. Okay, so let's now go to the next. Okay, here is a drawing. I mean, an illustration again of an anthropoid pelvis, gynecoid, and android pelvis. Okay. Now, for the pelvis, we have to determine if the pelvic cavity is of adequate size to allow for the passage of the full-term infant. Eh, di ba, diha man sa pelvis mo ang infant pag mag-vaginal delivery. So, we have to assess if adequate ba ang sukod sa iyang pelvis na makaagi gyud ang a fetus or infant or baby during delivery. So once again, the best pelvis or the best type of pelvis for a normal delivery is the gynecoid pelvis because it has the optimum shape fitted for delivery. So the pelvis is composed of the false pelvis and the true pelvis. The false pelvis, this part here, supports the weight of the uterus. It is like a shallow basin above the inlet. Okay, this is the inlet. So it's a shallow basin above the inlet. The true pelvis, on the other hand, this part here, represents the bony limits of the birth canal. So it is in this part where it should be measured, because the products of conception, especially the fetus or the infant, would go through here during a normal vaginal delivery. Okay, so the true pelvis is made up of these parts. We have the inlet, the mid-pelvis, and the outlet. The inlet is the upper margin of the symphysis pubis to the upper margin of the sacrum. The mid-pelvis, on the other hand, is the level of the ischial spine, this one. And the outlet is found at the lower pubic bone to the tip of the coccyx. Okay? So these are the parts of a true pelvis. As what I've said a while ago, we have to determine the size of the pelvis kung maiko ba ang pag-aki sa bata diha sa iyang pelvis. So what are the different pelvic measurements? First, we have the diagonal conjugate. This is the diameter or the size or the measurement which is measured from, this is the antero-posterior diameter of the pelvis. So this is measured between the sacral promontory to the inferior part of the symphysis pubis. And the average or the normal diagonal conjugate measures around 11.5 to 12.5 centimeters. Again,
Nakay klase?
diagonal conjugate.
Nakay klase?
Magkaan sarado?
Diameter.
Sa gate? Ako rin gawin sa ko rin tayo.
From the sacral promontory to the inferior margin of the symphysis pubis.
Murag
Ang
eh.
measurement niya, ang average or
Oh,
normal,
gain
is
na lang to siya. Gabiin mo
11.5
rin
to
siya.
12.5. We have to remember this because we will use this as a basis in getting the true conjugate. So the next measurement, or the next pelvic measurement, is the true conjugate or the conjugate vera, which is the actual opening of the pelvic outlet. Okay, so it is measured from the exterior surface of the sacral promontory to the superior margin of the symphysis pubis. It measures around 11 centimeters. Okay, or subtract the width of the symphysis pubis from the diagonal conjugate. Usually, the width of the symphysis pubis is 1.5. That is why I told you a while ago, we have to remember the diagonal conjugate measurement, which is 11.5 to 12.5, because we can use this in measuring the true conjugate. We are just going, whatever the result of the diagonal conjugate is, we are going to subtract 1.5 centimeters from that in order to come up with a true conjugate. For example, kung ang diagonal conjugate sa pelvis ni mama is 12.5 centimeters, minusan lang imog 1.5 centimeters, asa gikan ning 1.5, this is the width of the symphysis pubis. Diba? The formula is diagonal conjugate minus the width of the symphysis pubis. And the width of the symphysis pubis is around 1.5 centimeters. So you will get the true conjugate na 11 cm. Again, diagonal conjugate na 12.5 minus width of the symphysis pubis na 1.5 equals 11 cm. Therefore, the average measurement for the true conjugate or the conjugate vera is 11 centimeters. Next measurement is the posterior sagittal diameter of the outlet. Okay, posterior sagittal diameter of the outlet, or it is measured between the midpoint transverse diameter to the sacral tip, and it measures around 7 centimeters. Another pelvic measurement is the transverse diameter of the outlet. The transverse diameter of the outlet is measured between the two inner surface of the ischial tuberosities. So from one ischial spine to the other ischial spine, and it is around 10.5 to 11 centimeters. Again, diagonal conjugate is anterior-posterior diameter. I-measure siya from the sacral promontory to the inferior margin. Normal measurement, 11.5 to 12.5 centimeters. True conjugate is the actual opening of the outlet. It is measured from the anterior surface of the sacral promontory to the superior margin of the symphysis pubis. Okay? But you don't have to measure that. You just get the diagonal conjugate minus width of the symphysis pubis, the 1.5, and then you'll come up with the average or the normal value, which is 11 centimeters at true conjugate. Next is the posterior sagittal diameter of the outlet, which is measured from the midpoint or between the midpoint of the transverse diameter to the sacral tip. That's around 7 centimeters. And then the transverse diameter of the outlet, measured na siya between the two inner surfaces of the ischial tuberosities. It's around 10.5 to 11 centimeters. Okay, so that's the pelvis. Another P in the 4 P's of labor is the passenger. It's a passenger. Namuagi sa pelvis is the fetus. Okay. Usually, the most common position of the fetus is ang una mong gawas sa birth canal would be the fetal head, diba? The problem is the fetal head is the widest part of the body. So it makes it most difficult. It is the part of the body of the infant or the fetus which has more difficulty in passing through the vaginal canal because it is the widest part of the body. Okay? However, the passage depends on the bones, the sutures, the fontanelles. Remember that the fetal head has 8 bones, the sphenoid, the ethmoid, the frontal, and the occipital, and the 2 parietal bones, and the 2 temporal bones. Okay, so how does a very wide head of the infant able to pass through the pelvis of the mother or the maternal pelvis? Okay, it's because of the sutures, which allows molding. Sutures or intermembranous spaces would overlap together, will allow the bones to overlap together, and thus allow the head to pass through the vagina, or not the vagina but the pelvis rather. Okay, passes through the vagina, but the most difficult part of the maternal part or the maternal side is the pelvis. So what is molding? Molding is the overlapping of the sutures of the skull to allow passage of the head of the fetus to the pelvis. Alright. The fetal head also has 2 fontanelles, no? Katong wala pa mag-close na part sa head sa bata. We have the anterior fontanelle or the bregma, which is diamond in shape, and the posterior fontanelle or the lambda, which is triangular in shape. Okay? So the anterior fontanelle or the bregma is diamond in shape. The anterior-posterior diameter is around 4 centimeters, while the transverse diameter is around 2.5 centimeters. This fontanelle closes at 12 to 18 months post-delivery or after delivery. Okay, if the anterior-posterior diameter reaches more than 5 centimeters, then it may mean that the child may have hydrocephalus. Alright, so the other fontanelle is the posterior fontanelle or the lambda. This fontanelle is triangular in shape. And it measures 1 by 1 centimeter, meaning ang anterior-posterior diameter, 1 centimeter, ang iyang transverse diameter, 1 centimeter po. This fontanelle closes at 1 or 2 months old after delivery. Okay. The fetal head or ang ulo sa bata is wider in the anterior-posterior diameter than its transverse diameter. So mas lapad siya gikan diri sa tubangan hangtod sa likod kaysa iyang isig kakilid. Alright. So, what are the measurements of the fetal head? If we are going to measure the maternal pelvis, we are also going to measure the measurements of the fetal head. Tanaw na itong maigo ba siya moagi or paigo ba siya moagi ngadto sa maternal pelvis. Okay, one measurement of the fetal head is the transverse diameter. Transverse diameter is kilid sa ulo, no? Okay. Part of the transverse diameter is the biparietal diameter. The biparietal diameter is measured from one parietal eminence to the other parietal eminence. This is the largest transverse diameter and it measures around 9.25 centimeters. Another transverse diameter is the bitemporal diameter. So from one temporal lobe to the other, and it measures around 8 centimeters. And then another transverse diameter is the bimastoid diameter, which is the smallest transverse diameter, measuring only 7 centimeters. Okay, so mga transverse diameter ha, measurement sa kada left or right side sa ulo sa bata. Ang front to back or back to front, that is the anterior-posterior diameter. Okay, so what are the measurements of the anterior-posterior diameter? We have the sub-occipital bregmatic diameter. This is measured from the inferior aspect of the occiput to the center of the anterior fontanelle. So, gikan sa occiput ngadto sa center sa anterior fontanelle. The measurement is 9.5 centimeters, or the average measurement is 9.5 centimeters. This would be the size of the fetal head when the presenting part is, the sub-occipital bregmatic diameter is the presenting part if the child or the infant is in full flexion. Pag naka-full flex siya, mauna siya ang presenting part, ang sub-occipital bregmatic diameter. And it measures 9.5 centimeters. Okay? If we compare it to the other anterior-posterior diameter, pinaka-gamay siya. That's why the best fetal position nga dali ra siya moagi sa maternal pelvis is when the child or the presenting part is in full flexion. Okay, the next type of anterior-posterior diameter is the occipital frontal diameter. This is measured from the occipital prominence to the bridge of the nose. So from the occipital prominence to the bridge of the nose. And this measures around 12 centimeters. This would be the presenting part if the child is in moderate flexion. Okay? Nakaana. Dili kayo flex, nakaana lang gamay. And then we have the occipital mental diameter, which is the widest anterior-posterior diameter. This is measured from the posterior fontanelle to the chin. And it measures around 13.5 centimeters. This would be the presenting part when the child is in poor flexion or pag naka-hyper-extended ang head or ang presenting part sa fetus. Muning lisod siya kung paanakon kung maoning gauna ang occipital mental na diameter, no? Kay dako kayo moagi sa maternal pelvis. Imagine, kung sa'y pinakagamay na excuse me, unsay pinakagamay nga measurement sa maternal pelvis asa to na atay 7 centimeters, no? And then moagi ang 13.5 centimeters. So lisod kay siya moagi. Alright? Okay, next, molding. Diba? We said a while ago nga the sutures would allow molding. That is why it makes it also possible for the fetal head to pass through the maternal pelvis, although bisan pag dako-dako gamay ang fetal head, no? So, molding is a change in the shape of the fetal skull produced by the force of uterine contraction pressing the vertex of the head against the not yet dilated cervix. Pressure causes them to overlap and molds the head into a narrower and longer shape, a shape that facilitates passage through the rigid pelvis. So because of the suture, iba kay close ang mga bones sa bata sa ulo, so mag-overlap na siya, no? Okay, mo change ang shape, mahimo siyang talinis gamay, medyo murag cone head, no? That will allow passage of the fetus to the maternal pelvis. So katong pag-change sa shape sa iyang ulo will last for a day or two. So after 2 days, ibalik na dahil sa normal na circle or spherical shape ng ulo sa bata. Hindi na katungurang elongated. For 2 days lang na ma-elongated ang iyang ulo. There is little more molding when the presentation is a brow presentation or when the brow is the presenting part because the frontal bones are fused. Nang medyo lisod mga anak, okay, dako na daan, 13.5 centimeters na daan ang presenting part. Unya, di pa din makamold kaayo. So, lisod kaayo nga vaginal delivery. And there is no skull molding in breech presentation. Kaya alang-alang, di man ulo ang unang mo gawas, di ba? Ang lower portion man of the child's body or of the fetus's body. Okay, next thing we have to consider is the fetal attitude. The fetal attitude is the relationship of the fetal body parts to each other, or it is the degree of flexion of the fetal head when the chin touches, or our goal here supposedly is when the chin touches the sternum. Okay? Full flexion ang tawagan niya, and that is the best or the ideal fetal position or fetal presenting part. Again, fetal attitude is the relationship of fetal body parts to each other, or it is the degree of flexion of the fetal head. Alright, we have 3 types of flexion or fetal attitude. We have the complete flexion, the moderate flexion, and the poor flexion. The complete flexion, mag-anakit ang bata, no? Allows the smallest diameter of the skull to pass through the pelvic cavity. You mentioned that a while ago, na pag nag-full flexion ng bata, kadtong bubo lang 9.5 centimeter lang ang diameter ang una moagi sa maternal pelvis. Thus, the complete flexion is the best position. Alright, the other fetal attitude is moderate flexion. Moderate flexion is when head is less flexed, making the diameter wider. Moderate flexion is also called as the military or the neutral position. No? Kay murag straight body ang head sa bata. And then, the last fetal attitude is the poor flexion. Okay? Poor flexion, kay wala man mo touch ang chin sa bata sa iyang sternum, no? Naghangad ang bata kay face or brow presentation. Okay? So, in this type of attitude, it presents the skull diameter which is too wide, 13.5, diba? Making delivery difficult. Okay? So this is what will happen when the child is in full flexion attitude. Ang una mo gawas sa maternal pelvis would be the diameter of the fetal head, which is the smallest. Katong 9 or 9.5 centimeters lang ang muang itihan. Alright, another term which we should remember is the fetal eye. The fetal eye is the relationship of the long axis of the fetus to the long axis of the mother. Ang atua diring gamiton nga what you call this, sukdanan, is the spine of the mother and the spine of the fetus. Okay? So, longitudinal ang lay anak niya kung ang fetus naka-vertex or naka-breech position. Naglingkod or nagtuwad siya, that is longitudinal lie. In other words, the fetus is in vertical position in relation to the spine of the mother. Okay? Naka-vertical ang bata. That is longitudinal lie. Transverse lie siya kaning drawing na B. This is the transverse lie. It occurs when the fetus is horizontal in relation to the mother. In other words, nagbabag ang bata. That is transverse lie. Of course, this makes vaginal delivery impossible or difficult. That's why if the child is in transverse lie, we have to resort to cesarean section delivery. And then if the bata is unsay tawag ana diagonal diha, okay? Nag-ana iyang forma, that is what we call as the oblique lie. It is also it makes also vaginal delivery difficult. Alright, so let's now go to the fetal presentation. So the fetal presentation is that part of the fetus which first enters the maternal pelvis. So what are the different fetal presentations? First, we have the cephalic presentation. Cephalic presentation occurs when the fetal head is the presenting part. So ang unang mugawa sa maternal pelvis is the fetal head. So we have the vertex presentation kung naka-complete flexion ang bata. So this is the ideal position or the ideal presentation because it makes the passage of the first part of the fetal body, which is the smallest diameter. Okay, the military presentation when the child is in moderate flexion. If the child is in poor flexion or in extension, the presenting part would be the brow, or the presentation would be the brow presentation. And if the child's head is extended fully, then the presentation is called as the face presentation because it's the face which is the presenting part. Ang una mo gawa sa maternal pelvis. Another fetal presentation is the breech presentation. Okay, money ang breech presentation. You have the frank breech, full breech, and the single footling breech. So in a breech presentation, naka-vertex gyapon ang bata, no? Naka-longitudinal gyapon in relation to the mom's spine. Pero ang naguna sa iya dili na ulo, but the lower portion of the fetal body. So in complete breech, the thigh rests on the abdomen while the legs rest on the thigh. So mura siya og kani Indian sit siya, no? Ang iyahang thigh, ang iyahang paa, naa sa abdomen niya, ang iyahang legs, naa sa thigh. Okay. Incomplete breech occurs kung ang isa naka-frank breech, ang isa naka-complete breech. Another is frank breech presentation. The thigh is resting on the abdomen while the legs is extended to the head. So mao ni ang frank breech presentation, no? Murag naka-flex ang hip part sa bata and the thigh and the legs are extended fully towards the anterior part of the baby. And then we have the footling presentation. sa footling presentation, ang una mo gawas, ang pinakaduol sa maternal pelvis is the foot of the baby. And then napay isa kneeling, so mura galuhod ang bata ani kneeling presentation. Okay. Now, if the child is in transverse lie, parehas itong picture kaganina, this is the transverse lie. So, if the baby is on a transverse lie, so the presentation is the shoulder presentation. Ang una mo gawas, kung vaginal delivery siya, shoulder. But vaginal delivery is very difficult or is not possible when the child is in shoulder presentation. Okay. So another thing which we should consider also is the fetal position. The fetal position is the relationship of the fetal presenting part to the specific quadrant of the mother's pelvis. Relationships of presenting part, whether head, scaly, or face. So it's the relationship of the fetal presenting part to the specific quadrant of the mother's pelvis. The fetal position is described in 3 letters. The first letter represents the presenting part in relation to the mother's right or left side. Okay? So alam na this na pag ang first letter is R, it means nga ang presenting part naa sa right side sa mother. If the first letter of the fetal position is L, pasabot na niya, ang presenting part rests on the left side of the mother. The middle letter of the fetal position is the presenting part. So, O na siya kung occiput, M kung mentum, S kung sacrum. Okay, sacrum na siya kung naka-breech, di ba? The last letter of the 3 letters represents the landmark, which is, the landmark is the anterior, posterior, or transverse in relation to the mother's spine. Okay? So, these are the common positions in vertex presentations. You have LOA. What does LOA mean? L stands for left, O stands for occiput, A stands for anterior. Meaning, ang presenting part naa sa left side sa mother. Okay? Ang presenting part, occiput, or the head. Okay? Aside being on the left side of the mother, the occiput is also resting on the anterior part of the mother. Okay? So that is LOA, or left occiput anterior. What does ROT means? Right occiput transverse, meaning the presenting part is the occiput, which rests on the right side of the mother, but in the transverse side of the mother. So nag-side view siya sa mother. Then we have right occiput posterior, right occiput anterior, left occiput transverse, and left occiput posterior. Okay, so how do we determine the position of the fetus or the fetal position? First, determine the presenting part, whether occiput, mentum, or sacrum. And then, divide the mother's pelvis into 4 imaginary quadrants. Anterior, posterior, we also have transverse pala, and then right or left. Then, you will know what is the fetal position. Okay, for example, ang presenting part na adiri sa 9 o'clock. 9 o'clock. Ang presenting part, occiput, na adiri sa 9 o'clock. So, unsay tawag ana ang position? Right occiput transverse. So, that is how you are going to determine the fetal position. Okay, so right occiput posterior. The presenting part is the occiput. Ang occiput naa sa right side sa mother, naapod siya sa posterior part sa mother na quadrant. Diba? This is the left occiput posterior. The occiput is the presenting part, but it's found at the left side of the mother and posterior part of the mother also. This is the right occiput anterior. The presenting part is the occiput. It rests on the right side of the mother, and naa siya nakarest po sa anterior part sa mother. This is left occiput anterior. The presenting part is the occiput. It rests on the left side of the mother and also on the anterior part of the mother. So, imo lang imagine nun ni quadrant, kaning 4 quadrant sa mother's pelvis. Okay? Right, left, and then anterior, posterior. This is transverse. So that is how you are going to determine the fetal position. So the most common and the most favorable position is the left occipital anterior. The most common malposition is the right occiput transverse. The most painful, right occiput posterior and left occiput posterior. The management here to relieve pain is pelvis squatting or pelvic squatting. Okay, so for breech presentation, in getting the fetal heart rate, we have to place the stethoscope above the umbilicus. Unlike when the child is in occiput presentation, we have to locate it somewhere. Basta pakita nga to ang fetal back, no? That is where we are going to take the heart rate of the baby. And then, for chin presentation, the presenting part is the mentum or the chin. Then shoulder, the acromiodorsal. Okay, next we go to the station. What is the station? The station is the relationship of the presenting part of the fetus to the level of the ischial spines. Kato ischial spine, katong murag sungay, no, sa maternal pelvis, katong may nagburot sa maternal pelvis. Alright. So, muna atong mailhan para ma-determine nato ang station sa bata. Okay. Zero station ang tawag nato ana when there is already completion. Meaning, the fetal presenting part is at the level of the ischial spines. Do we have the diagram here? Wala. Okay? So, zero station na siya kung engaged na ang presenting part. When you say engaged na presenting part, naana siya sa level sa ischial spines. If the presenting part is above the ischial spines, it means that the fetus is still floating. Wala pa engagement. So, pa siya ma-engage. Nag-float pa siya. And that is usually represented with the minus stations. Negative 1, negative 2 to negative 4 centimeter or station. If the presenting part is below the ischial spines, plus station na siya. Plus 1 up to 4 cm. So when it is already plus 3 or plus 4 station, it may mean that the presenting part is already in the perineum and can be seen if the vulva is separated. We call that as crowning. Usually, ulo magiging ang una nga presenting part, no? So, ang ulo, makita na nimo if imong i-separate ang vulva, if ang ulo na nasa perineum, crowning ang tawagan na niya. And the station is usually plus 3 to plus 4. Okay. Next piece of labor is the power. Power is the force acting to expel the fetus and the placenta. So, itong unang nga P, pelvis. Second is the passenger or the fetus. Okay. Then we have the power or the force acting to expel the fetus and placenta. This is furnished because of the involuntary contractions of the uterus plus the voluntary bearing down efforts. Okay? One power of labor. Ang involuntary contraction of the uterus ug ang voluntary nga pag-utong sa mother or pag-ire ng mother or the bearing down efforts of the mother. So characteristics of the contraction of the uterus is wave-like. Now, if the mother is already in labor or the uterus is already contracting, as nurses, we have to assess the timing, the frequency, the duration, and the intensity of the contraction. We consider the myometrium or the muscular layer of the uterus as the power of labor. So remember that the uterine contraction is the primary force moving the fetus, okay? The primary force moving the fetus through the maternal pelvis during the first stage of labor. Again, the primary force which moves the fetus through the maternal pelvis during the first stage of labor is the involuntary uterine contraction. The maternal contractions, on the other hand, is when the woman adds voluntary pushing force to force of contraction during the second stage of labor to propel through the pelvis. So primary force, involuntary uterine contraction. Secondary force, the voluntary uterine contraction exerted by the maternal bearing down. Okay? Or the abdominal muscles assist in the second stage of labor while pushing. Pag-utok, pag-ere sa mother, which increases the intra-abdominal pressure to aid in the expulsive forces. The last P in the 4 P's of labor is the psyche or the person. This is psychological stress exists when the mother is fighting the labor experience. Meaning, if the mother go against the labor experience, it will just end up in stress. So that's why some relaxation techniques would say that you just go with the flow. Okay, when you're in labor, you just go with the flow. Do not try to fight it because it's a natural experience. So it is important that we prepare the mother how to interpret the labor experience, especially cultural interpretation. We also should consider the past experience of the mother. If the past experience is positive, we may use that now to relieve anxiety and stress and pain. If the past experience is negative, then we could provide encouraging health teachings, which will somehow condition the mother to have positive thoughts about labor and delivery. Of course, especially among Filipinos, support system is very important, no? Kung taas man ang moral sa tao, kung nadiha iyang husband, kung nadiha iyang mga family members, during the time na sa stressful labor and delivery. So we have the psychological responses to the birthing process. It is important that the mother is prepared for childbirth. So childbirth preparation or preparation for childbirth should be done prior to labor and delivery. This includes childbirth classes and prenatal care. And then we also should consider the previous childbirth experience. Was it complicated? Was it okay? Then support from significant others. You have to determine if the woman is separated. If yes, then who else could be the support person of the woman during labor and delivery. We also have to assess marital state, okay, any abuse to consider during labor and delivery. And then we should also consider the emotional status of the pregnant mother, the culture, because background may influence the response to pain. Some moan, some are very verbally expressive, while some are so secretive, no? Bisag sakit na kaayo, di pa siya free ma-express sa iyang pain. That's because of cultural, iyahang namatan sa iyang culture. And then consider fear and anxiety, which may exacerbate pain. Okay, so let us now go to the changes which may occur during labor and delivery. First, we have cardiovascular system changes. During each contraction, blood flow to the placenta gradually increases, resulting in an increase in the woman's blood volume, causing her breathing to increase and slowing her pulse. Okay? So, kada mo contract ang uterus, pasabot ana niya, ang mahitabo ana niya, ang pag-flow sa blood ngadto sa placenta niya will decrease. So, gamay ra blood flow sa infant or sa fetus, pero ang blood volume sa mama mo increase. That's why mo taas yung BP kada contract sa uterus. Mo slow po yung pulse kada contract sa uterus. Because these changes occur during a contraction, it is best to assess the vital signs between contractions. Do not assess the vital signs during contraction, but assess the vital signs between contractions so that you can get the real or the actual vital signs which is not affected during contraction. Next, we have respiratory system changes. So during labor, a woman is likely to hyperventilate. Diba? Pag sakit na kaayong contraction, may tabo sa mama, maghalhal. So, what will happen if the mother is hyperventilating? It will lead to tingling in the hands and feet, numbness, and dizziness. So what are you going to do? You let or have the woman slow her breathing or breathe into her hands or a paper bag so that ma-conserve niya ang carbon dioxide. Okay, because the tendency in hyperventilating is daghan kay siya, there is over-release of carbon dioxide. So ipahina-hina lang breathe or pwede pa-breathe siya through a cup hand or into a paper bag. Okay. Another changes during labor and delivery, changes in the woman's body, is the gastrointestinal system changes. Most women are limited to clear liquids during labor and delivery or even NPO. Nothing by mouth, nothing per oral. During labor process. Nga naman. Because gastric motility and digestion of food, gastric motility and digestion of food is reduced. So, i-clear liquids lang siya during labor and delivery or i-NPO, walagi, nothing by mouth yun, nothing per oral yun, para ma-reduce ang gastric motility and digestion of food. Para ma-decrease ang risk of aspiration. Okay, next change, we have the urinary system changes. Okay, so what happens during labor and delivery is that the intense contractions, tungkol sa pag-contract sa uterus, napapit sa kita, there is a reduced sensation of the needing to void. Okay? Plus anesthesia, it will lead to unawareness of having a full bladder. Tungod sa intense contractions plus anesthesia, dili na aware ang mama nga puno na day iyahang bladder. Okay? So, may tabo, di siya kaihi, puno yung bladder. So, what will happen is that if the bladder is full, that will inhibit fetal descent or causes increased discomfort if there is no anesthesia. Wala anesthesia, feel uncomfortable ang mother. Plus the fact na pag full ang bladder, It will inhibit the fetal descent. Hinay ang pagbaba sa bata ngadto sa birth canal. Alright, next we go to the hematopoietic system. Okay, the estimated blood loss during delivery for vaginal delivery it's around 500 ml. For cesarean birth it's around 1000 ml. Clotting factors are elevated and fibrinolysis is decreased to promote coagulation at the placental site. Okay, let us now go to the preeminent signs of labor. Sa may mga kumbaga warning signs of labor. We have lightening. Lightening either is the settling of the presenting part into the pelvic brim. Usually, the woman feels this as a shooting pain radiating to the legs, causing urinary frequency. The lightening will cause shooting pain, which radiates to the legs and causes urinary frequency. Ano may tabo ko mag-lightening? Lightening is the settling of the presenting part into the pelvic brim. For primipara, this occurs early, about 2 weeks prior to the expected date of delivery. Okay? For multipara, medyo late na siya makita po. Okay, next we have engagement. Engagement is the settling of the presenting part into the pelvic inlet. Next, we have Braxton-Hicks contraction. Braxton-Hicks contraction is a painless, irregular contractions or false contraction. And then we have increased activity of the mother. So there is now the nesting instinct, or the distinctive urge to clean, tidy, and organize that occurs during pregnancy. So, wala na feeling ang mga hapit na di siya mga anak. So, mauna nga, busy na kayo siya, i-prepare ang nursery, i-prepare ang mga lampin diha. Unsa pa na diha niya i-prepare. Our management here, since grabe ka busy si mama, murag bird ba nga, busy na kay himog nest, kay mangitlog na siya. So, since the mother is very busy, kaya nag-increased activity siya, so our management is to save energy. Another preeminent sign of labor is the slight loss of weight. As progesterone level falls, body fluids is more easily excreted from the body. This increase in urine production can lead to a weight loss between 1 and 3 pounds. Okay, so pag bumubo sa progesterone, pag hapit ng mga anak ang mama, sige na siya ihi-ihi. So fluid is more easily excreted from the body. Tungod sa iyang sig ihi-ihi, so mag-weight loss ang mama around 1 to 3 pounds. Next preeminent sign of labor is the ripening of the pelvis. Ripening of the cervix. The ripening of the cervix can only be seen in pelvic exams. So, unsay mahita po sa cervix ani, it becomes butter soft and tips forward. Dili ka ng butter nga ibutang sa freezer ha. Kanang butter nga naa sa room temperature. Okay. Excuse me, as I can see, daghan kaayo nga magsigig enter sa waiting room, from the waiting room. Please find a stable internet connection, ha? Kaya basta i-full screen ako ning video, di na ko makita kinsay magpa-admit. So madugay gid mo admit, di man siya mo notify pag naka-full screen. So please find a stable internet connectivity, stable internet connection para di mo magkawawa sa classroom ay sa Zoom. Again, find a stable internet connection para di mo ma-out sa Zoom. Kaya naka-full screen ning akong video, dili ko ma-notify if na ay mosulod.
So I have to
na siya butter soft and it tips forward. This is the ripening of the cervix is an internal announcement that labor is very close at peak inlet. Next, we have Braxton Hicks contraction. Mama management is to save energy. Another preeminent sign of labor is the slight loss of weight. As progesterone level falls, body fluids is more easily excreted from the body. This increase in urine production can lead to a weight loss between 1 and 3 pounds. Okay, so pag umubo sa progesterone, paghapit ng mga anak ang mama, sige siya ihi-ihi. So fluid is more easily excreted from the body. Tungod sa iyang sig ihi-ihi, so mag-weight loss ang mama around 1 to 3 pounds. Next preeminent sign of labor is the ripening of the pelvis. Ripening of the cervix. The ripening of the cervix can only be seen in pelvic exams. So, unsay mahita po sa cervix ani, it becomes butter soft and tips forward. Dili ka ng butter nga ibutang sa freezer ha. Kanang butter nga naa sa room temperature, okay, na siya butter soft and it tips forward. This is the ripening of the cervix is an internal announcement that labor is very close at hand. Alright, so what are the signs of true labor? Ito warning signs, not the preeminent signs lang. But what if when true labor sets in? How would you know? So the signs of true labor includes uterine contraction. Of course, this is the surest sign that labor has begun. Next, we have the bloody show. This is a pinkish vaginal discharge made up of blood plus leukorrhea plus operculum. It is pink tinge. Next, we have rupture of membranes. This is a sudden gush or a sleepy, slow seeping of clear fluid from the vagina. This can cause the fetal head to settle snugly into the pelvis, actually shortening labor. However, it carries along risks with it, like intrauterine infection and prolapse of the umbilical cord. So once ROM occurs, or the rupture of membrane occurs, one of our nursing responsibilities is to check the fetal heart tone. Check yun. Kay prone siya sa prolapse of the umbilical cord. Okay, you also do an internal examination to check for cord prolapse. And after several hours, check the temperature of the mother because intrauterine infection could occur after the rupture of membranes. Okay, during an internal exam, we will be able to assess the cervix or the cervical assessment. Two things are to be assessed during a cervical assessment: the dilation and the effacement of the cervix. What is cervical dilation? Cervical dilation is the opening of the cervix or the size of the cervical opening, which is measured in centimeters. So from 0, kung pa siya ma-open, ang full dilation niya is 10 centimeters. Effacement, on the other hand, is the estimated amount of the thinning of the cervix. So ang pagnipis sa cervix, and it is measured in percent. So 0% kung wala pa siya ma-thin, 100% kung completely effaced na. Meaning, mura na siya og paper thin. Mura na siya papel kanitsa. Munang 100%. So, ning dilate ang cervix, ning nipis pagyod ang iyahang surface, so dali na lang kaayo mo agi. It facilitates now the passage of the fetus or the presenting part of the fetus. Again, dilation is the opening of the cervix. Full dilation is at 10 centimeters. Effacement is the thinning of the cervix. Complete effacement is 100%. Okay, so mauni siya ang illustration at oo. Okay, so kani mauni siya ang dilation nga itong tanawon, no? I mean, ang thinning. Okay? Then, diri ang dilation. So, mauni siya nga thin na siya. Diri, baga pa kayo siya, no? Kani, thin na kayo siya. Mauni siya ang effacement. And then, kani, ning open na, mauni siya ang dilatation. So, pag fully dilated na siya, plus thin tagyog guys nga tanan, it's easier now for the presenting part to pass through it. Okay. So again, we have the station. Station is the degree that the presenting part has descended into the pelvis in relationship to the ischial spine. So these are the ischial spines now of the maternal pelvis. If the presenting part, this one, kaning vertex sa bata, naagali na siya diri sa level sa ischial spine, pasabot ana engaged na ang presenting part. 0 ang station ana niya. But in this illustration, napaman siya sa ibabaw ang presenting part. Ibabaw siya sa ischial spine. Unsay tawag ani niya? The fetus is still floating. Negative ang kwenta ana niya. Dala ang measurement sa estimate 0, negative 1, negative 2, negative 3, negative 4, negative 5 centimeters. So, asa na bilong ang presenting part sa bata? Negative 2. So, mo na yung station. Negative 2. Since negative siya, floating na siya ibabaw sa spine. Pag abot aning iyang presenting part diri sa level sa ischial spine, 0 station na siya or engaged na siya. Pag mulampas na siya diri sa ischial spine, positive na siya nga station. Positive 1, positive 2, 3, 4, and 5. Okay? It means pagawas na ang baby. The goal here is to move from negative stations to positive station. Okay? Para magawas na ang bata ngadto sa birth canal. Alright. Let us now compare the difference between true and false contraction. Uterine contraction. Okay, in false uterine contraction, the contraction begins and remains irregular. In true labor contraction, it begins irregularly but becomes regular and predictable. In false uterine contraction, it is felt first abdominally and remain confined to the abdomen and groin. But for true labor contraction, it is felt first in the lower back, sa batang dapit na siya muuna, and it sweeps around to the abdomen in a wave. So magsugod sa likod, padung sa abdomen, padung sa tiyan. False uterine contraction often disappear with ambulation or sleep, while true labor contraction continue no matter what the woman's level of activity is. No? I remember last time, I was really in pain when I was in labor, no? Patulugon ko. But even when I was forcibly, put into sleep, I could still wake up and feel the pain of labor contraction. It's really very painful. And it does not disappear. The pain, the contraction does not disappear even when the woman is sleeping. Whatever the level of activity is, padayon gihapon ng contraction. Now, in false labor contraction, there is no increase in duration, But in true labor contraction, there is increase in duration, frequency, and intensity. Okay, in false labor contraction, there are no cervical changes. But in true labor contraction, there is now the increase in the percentage of cervical effacement and the increase in the centimeters of the dilation. These are the best major signs of true labor, kaning cervical effacement and dilation. Okay. Now, how long would labor take place? For primiparas, it's around 14 hours but not more than 120 hours. For multipara, 8 hours but not more than 14 hours. Okay. So next we go to the maternal and fetal evaluation during labor with an electronic external or internal monitoring. So using machines to assess the fetus and the mother during labor. Cardiotocography is a technical means of recording the fetal heartbeat and the uterine contractions. It makes use of the cardiotocograph or the electronic fetal monitor or the EFM. This is a machine used to perform the monitoring. It is widely used to assess fetal well-being. A typical cardiotocography reading is printed on paper and or stored on a computer for later references. Excuse me. External cardiotocography is done for continuous or intermittent monitoring. The fetal heart rate and the activity of the uterine muscles are detected by two transducers placed on the mother's abdomen. Doppler ultrasound provides the information which is recorded on a paper strip known as a cardiotocograph. Okay? So this is how an external cardiotocography looks like. Mao ni siya ang transducers na ibutang sa abdomen sa mother to detect uterine contraction, and the other one is to detect or assess the fetal heart rate or the fetal heart tone. Okay, so mao ni mahitabo. Ang isa ka transducer is to sense uterine contraction. Ang isa ka transducer is to sense the fetal heart rate. This is the external fetal monitor. Now, what are the advantages of external fetal monitoring? They could evaluate contraction and fetal heart rate, and it provides written record for contraction and fetal heart rate. The disadvantage is that it may be inaccurate when the mother is moving or when the fetus is moving. So, maapektuhan na resulta due to maternal and fetal movements. Another is, it needs experienced clinician to read the results, otherwise the information can be misinterpreted. Now, another type of electronic fetal monitor, external man to kaganina, no? This time it's internal cardiotocography. This uses an electronic transducer connected directly to the fetal scalp. Diretso siya sa ulos bata. Nara, oh. This is the fetal scalp electrode. Okay? Which monitors the heart rate of the fetus internally. Very invasive siya. Kay moabot ko siya internally sa bata, no? So, it carries along a lot of risk. However, it is more accurate than the external fetal monitoring. Okay. So it uses a spiral or a scalp electrode, just like what I've shown you a while ago, which is a wire electrode that is attached to the fetal scalp through the cervical opening and is connected to the monitor. As what I've said, it may be invasive, it may be risky, dangerous, but it provides a more accurate and consistent transmission of the fetal heart rate than the external monitoring, because factors such as movement do not affect it. Unlike the external monitoring, di ba, mautro ang, pwede ma-accurate ang result brought about because of maternal and fetal movements. But this one, in internal cardiotopography, it it is not affected by maternal and fetal movements. Internal monitoring may be used when external monitoring of the fetal heart rate is inadequate or when closer surveillance is needed. So again, internal monitoring is more accurate. This method can only be used if membranes and cervix have ruptured, either spontaneously or artificially. Alang ano, saan pagsulod ana niyang internal nga mga device kung closed pa ang cervix. Okay. So the fetal scalp electrode is a wire electrode attached to the scalp of the fetus to monitor the fetal heart rate accurately and continuously. Advantage, precise assessment of the fetal heart rate, and the results are not affected by fetal movement. Disadvantages, it may cause lacerations of the fetal scalp, and the mother also cannot ambulate. Okay, another wire which is inserted during an internal fetal monitoring, aside from the fetal scalp electrode, we have the IUPC, or the intrauterine pressure catheter. It is inserted into the uterine cavity to measure or monitor the contractions precisely and continuously. What are the advantages of the intrauterine pressure catheter? It provides a precise assessment of maternal contractions. The mother can turn side to side, so the mother can freely move. And it measures the intensity or the strength of the uterine contraction internally, which usually reaches around 30 to 50 millimeters of mercury during the peak of contraction. The disadvantages of the intrauterine pressure catheter: it increases the risk of maternal infection, and the mother cannot also ambulate. Okay, so this is the fetal scalp electrode, which measures the fetal heart rate internally. This catheter here, this is the IUPC, or the intrauterine pressure catheter, which also measures the uterine contraction internally. Okay? So, mas precise ni siya ang internal, mas risky lang or mas dangerous. Excuse me. Okay, so interpretation of a cardiotopograph tracing requires both qualitative and quantitative description of the uterine activity or uterine contraction, the baseline fetal heart rate, the baseline FHR variability, the presence of accelerations, periodic or episodic decelerations, and changes or trends in the fetal heart rate patterns over time. Excuse me. Okay, so what are uterine contractions? This is the tightening and shortening of the uterine muscles. Hingahi ang muscles sa uterus para ni siya ma-push ang bata pagawas sa uterus. During labor, contractions accomplish two things. It leads to cervical dilatation and effacement, and it helps the fetus to descend into the birth canal. The contraction exhibits a wave-like pattern that begins slowly climbing. So this one, morning wave-like pattern no, sa uterine contraction. Mao po ni siya ang mugawas sa imuhang cardiotocograph result. No? So, ang pagsaka, that is the increment, ang peak niya, this is what we call as the acme, and ang pag-ubos, ang pag-decrease sa wave, that is the decrement. So as soon as each contraction starts, mo na siya diri magsugod sa increment. Ang peak sa contraction is the acme. Ang paghinay-hinay o kawala or decrease sa contraction is the decrement. And then it starts again later on. So the increment, the peak or the acme and the decrement is what we call as the three phases of uterine contraction. So increment, the start of the contraction until it reaches the peak or acme. So acme is the peak of contraction. And then pag hinahini o kawala or ka-decrease sa contraction is the decrement. Then the uterus undergoes a resting period. And then balik na po the contraction, increment, acme na po o decrement. Now, when electronic fetal monitors are being used, the contraction of the uterus are also being assessed. So what are being assessed when we talk about uterine contraction? Ma-assess ang duration, ang frequency, ang interval, o ang intensity. Okay, what is duration? The duration of the contraction is monitored from the beginning of one contraction to the end of the same contraction. So the duration is the span of time which is measured from the beginning of one contraction to the end of the same contraction, meaning unsa kadugaya ang isa ka contraction, that is duration. This usually lasts 30 seconds in the early phase and 60 seconds in the active phase of contraction. So duration beginning of one contraction to the end of the same contraction. Another thing which you should assess in uterine contraction is the frequency. The frequency is the amount of time spent from the beginning of one contraction to the beginning of the next contraction or another contraction. So, gikan diri sa sugod sa isa ka contraction until sa sugod na pod sa next contraction, this is what we call as the frequency. Okay? In early labor, this occurs every 15 to 30 minutes, and in active labor, every 2 to 3 minutes. So, magkadugay ang labor, magkataas ang duration, magkamubo ang frequency. Alright. Another thing which we should consider or we should assess during uterine contraction is the interval. The interval is the resting time between contractions, which allows for placental perfusion. Para daghay blood flow sa placenta. E kung magsigig contract, walay resting state, walay interval, walay blood flow ngadto sa placenta, walay oxygen, walay nutrients nga moadto sa bata. So that is the interval, the resting time between contractions. Another thing which we should assess during a contraction is the intensity. It is a measure of how strong a contraction is. If you are monitoring the intensity externally, you are going to use palpation to determine relative strength. So, taas ang intensity kung ang uterus inihikap nimo perting gahiya. Na grabe ka intense ang iyahang contraction. But, the internal monitoring could determine the accurate intensity of the contraction. Okay? So it determines, the IUPC determined by assessing actual pressures as graphed on the paper. It's around 10 millimeters of mercury. Alright, so again, the resting tone is the period of uterine rest between contractions. So again, what are we going to assess during contraction? One is duration. This is assessed from the beginning of one contraction to the end of the same contraction. Frequency, beginning of one contraction to the beginning of the next contraction. Interval, end of one contraction to the beginning of the next contraction. Meaning this is the resting time between the contraction. Intensity measures the measure of how strong the contraction is. Okay. In assessing the contraction, we have to consider the subjective symptoms by the woman. And then palpation and timing by the nurse, and use of electronic fetal monitor when available. Be careful not to rely on verbal cues from the mother regarding contraction and labor progress. Ano man, it may be misleading, giving false impression of good labor pattern. There are women who could act as if they're always in pain. So magtuo ka nga, hapit ka din yung mga anak, kay yung grabe na ang intensity. Yung nagpirma na siya, so ang iyahang, what you call this, frequency of interval, hapit na din siya mga anak. Pero wala, grabe lang dahil ka-low ang pain tolerance sa mother, no? Napoy uban, sige ngising-isi, pero grabe na dahil contract ato, no? Hapit na mga anak, nag-crowning na, gagising lang gihapon. So, it really differs from one person to another. That's why, do not rely on verbal cues from the mother. Also, do not rely because contractions may be more or less intense than what the patient reports, and the nurse may miss forceful contractions because of excellent coping skills or high pain tolerance of the mother. Man akong giingon, nga, nag-crowning na lang, gangising-isip pa, murag wagid ka feel sa pain, kay taas kay siya pain tolerance. As mentioned a while ago, during each contraction, blood flow to the placenta gradually decreases, resulting in an increase in the woman's blood volume, causing her BP to increase and slowing her pulse. So because these changes occur during a contraction, when are we going to assess the vital signs? In between contractions. How do uterine contractions affect the fetal heart rate? It can cause, or the uterine contractions can cause a decrease in the fetal heart rate through fetal head compression, naipit, na-compress ang ulos bata, or umbilical cord compression, ang iyahang umbilical cord na na-compress or naipit, or uterine myometrial vessel compression. Ang blood vessels sa uterus na-compress. Mo nang decrease ang blood flow, decrease ang fetal heart rate. Assessing and interpreting fetal heart rate patterns involve evaluating 3 parameters. What are these parameters? We have the baseline rate, variabilities in the baseline rate, whether long-term and short-term, and the periodic changes in the rate, which includes acceleration and deceleration. Okay, let's start with the baseline fetal heart rate. Ano na siya? The baseline fetal heart rate is determined by approximating the mean fetal heart rate rounded to increments of 5 beats per minute during a 10-minute window, excluding accelerations and decelerations and periods of marked FHR variability. It is greater than 25 beats per minute. In other words, the baseline fetal heart rate is determined by analyzing the range of fetal heart rate recorded on a 10-minute tracing that was obtained between contractions. 1 minute naman din ang fetal heart rate, di ba? Pero kung unsa iyahang average na fetal heart rate na imong gikuha within 10 minutes, kada minute pero 10 minutes, then that is the baseline fetal heart rate. The average fetal heart rate that occurs between contraction during 10-minute period. This is another definition or description of the baseline fetal heart rate. So the baseline fetal heart rate is the average fetal heart rate that occurs between contractions during a 10-minute period. Normal baseline fetal heart rate is 120 to 160 beats per minute. The accelerations and decelerations are not counted. It may fluctuate slightly for 5 to 15 minutes when a fetus moves or sleeps. So that's the baseline fetal heart rate normal, 120 to 160 beats per minute. If the fetal heart rate is below 110 beats per minute for 10 minutes, then that is a condition called as bradycardia. Okay? Below 100 beats per minute is a sign of fetal hypoxia or a danger sign. This may be seen when there is prolapse cord o fall below 100 beats per minute ang yung fetal heart rate. That is bradycardia. Tachycardia, on the other hand, is a fetal heart rate which is more than 160 beats per minute for 10 minutes. What causes tachycardia? We have maternal temperature and infection such as chorioamnionitis. Okay, what is FHR variability or fetal heart rate variability? This is one of the most reliable indicators of fetal well-being. If no variability is present, it indicates that the natural pacemaker activity of the fetal heart has been affected. In other words, naagay variability. Ay kung walay variability, it means na ang iyahang natural pacemaker or the sinoatrial node is affected, which may occur as a response to narcotics and barbiturates administered to a woman in labor. The baseline fetal heart rate variability are fluctuations in the baseline fetal heart rate that are irregular in amplitude and frequency. It is determined in a 10-minute window, excluding accelerations and decelerations. Okay, 1 minute na yung makuha ng fetal heart rate, but you have to get the average within 10 minutes. Fluctuations are visually quantitated as the amplitude of the peak to trough in beats per minute. Okay, the variability is categorized by the quantitated amplitude, okay, such as absent or undetectable, minimal, greater than undetectable, but less than or equal to 5 beats per minute, moderate, 6 to 25 beats per minute, marked, greater than 25 beats per minute. Long-term variability results from fluctuations in the fetal heart rate that occur 3 to 10 times per minute. Short-term variability or beat-to-beat variability, on the other hand, is the difference between successive heartbeats, usually about 3 to 5 beats per minute. Again, baseline variability or baseline fetal heart rate variability are fluctuations in fetal heart rate of more than 2 cycles per minute. There are times nga muhinay ang fetal heart rate but not below normal, no? This is a normal and expected finding. It should always be present and appears as jitters. Kung sa iyang significance, muhinay ang mapaspas. Not only muhinay ang mapaspas, but not, excuse me, not below normal and not above normal. So, ang pasabot ana niya, it indicates fetal well-being. Meaning, normal ra ng baseline FHR variability. Kung naa na siya, it indicates fetal well-being. Kung wala na siya, mo'y delikado. It is caused by the natural pacemaker's ability of the fetal heart due to the effects of sympathetic and parasympathetic nervous system. Okay, so what are your nursing interventions when baseline FHR variability is present? So we'll continue to monitor and assess the tracing every 15 minutes. It should show a 6 to 25 beats per minute fluctuations within a 1 minute period. Heart rate of 120 reaching 135 beats per minute is reassuring. That's a normal baseline FHR variability. The problem is when there is decreased variability. Okay? What's the main cause of decreased variability? You have hypoxemia or acidosis, fetal sleep cycles, drugs like analgesics, barbiturates, tranquilizers, anesthetics. It could also be due to prematurity, arrhythmias, and fetal tachycardia, or a pre-existing neurologic abnormality or congenital anomalies. So, nursing interventions for decreased variability. Again, ang FHR variability or baseline FHR variability, normal. Ang dili normal, decreased variability. Na na-cause ani niya hypoxemia to congenital anomalies. So, what do we do when there is decreased variability? We do a fetal acoustic stimulation to wake the fetus. We usually, in this intervention, we usually use a vibroacoustic stimulus such as an electronic larynx or artificial larynx applied either externally or directly to the fetus. And ang resulta niya, pagmukuratan ang fetus, so there will be fetal movements, cardio acceleration, and alterations in respiration. Okay. Another nursing intervention is Narcan. Giving of Narcan rather. Narcan counteracts the life-threatening depression of the central nervous system and the respiratory system. Another intervention is amnio infusion to decrease cord compression and to dilute the meconium. And then we have to advise the mother to maintain a left or right lateral position or knee-chest position. This is to relieve the pressure of the cord, no? So left or right lateral position or knee-chest position. And then you have to notify the doctor, get the fetal skull pH, prepare for possible emergency cesarean section, provide intravenous fluids, and oxygen therapy. Another thing which we should monitor in the fetal heart rate are the periodic changes or the fluctuations in the fetal heart rate. This occurs if these occur in response to contractions. Periodic changes are described in terms of accelerations and deceleration. Periodic changes are short-term short-term changes in the rate rather than the baseline. Okay? Di pareha sa baseline variability, di ba?
Mr. Molina, please
Changes
turn your
on the
mic off.
baseline. But in periodic changes, short-term changes in the rate rather than in the baseline. This lasts from a few seconds to 1 to 2 minutes. So what are the different periodic changes? You have acceleration.
Please turn your mic off, Mr. Molina and Miss B. Molina. Mamamati si Mr. Molina.
Early deceleration, late deceleration, and variable deceleration. What are accelerations? Accelerations are visually apparent abrupt increase in the fetal heart rate. An abrupt increase is defined as an increase from the onset of acceleration to the peak in less than or equal to 30 seconds. It is a short-term rise in the heart rate of at least 15 beats per minute, lasting at least 15 seconds. Again, accelerations are short-term rises in the heart rate of at least 15 beats per minute, lasting at least 15 seconds. May paspas yung heart rate gamay. And this is normal. Acceleration means that fetus has an adequate oxygen supply, which is very critical in assessing the fetus. Or the oxygen supply is